Okay, we're started.
All right, hey guys, welcome to week 8. So today, unfortunately, we have none of you guys here with us because you guys apparently have a farm shoot, but it's okay. We're recording this, so if anyone wants, it's on the YouTube. We'll send you guys the link after this as well as the slides. So let's get started. This week, you guys have a topic called envenoming, and it's about you know, snakes, jellyfish, spiders, all the different bites and what you do about it. It's like first aid and whatnot. So just a bit of a general definition. What's the difference between something being venomous and something being poisonous? But something that's venomous has an apparatus that like actually will secrete the venom or like inject into something, whereas something that's poisonous doesn't have that. So it's only be like you ingest it or something like that, you'll get the toxin and the poison spreading. And so an example would be a scorpion versus a frog. Yeah. In terms of snakes, just in general, a snake's venom, we call it a mosaic of different antigens. And what that means is there's all these different proteins that do different things just chucked in there. And so it'll have so many different effects. So that we've got specific things called myotoxins, which act on skeletal muscles and mess them up. You've got hemotoxins, which cause blood coagulation. You've got nephrotoxins, which act on the kidneys and cause kidney nephron damage and things like that. You've got cardiotoxins, which act on the heart, and then finally neurotoxins, which act on the N-O-J, which is the neuromuscular junction. And there are two sort of subgroups there. You guys will do the neuromuscular junction in more detail later on in farm. For now, just if you remember, we talked about there's always one neuron, we call it presynaptic, and then the second one that's getting the transmissions is postsynaptic and things like that, or like whatever is receiving is the postsynapse. So we've got beta neurotoxins, which act presynaptically on that first neuron, that one that's coming in. And what they do is they irreverse the effects for beta neurotoxins. It's slow, but it's irreversible. So if you don't respond to it quickly, like if you don't give antivenom quickly, then you can't reverse the damage that's caused there. And usually vipers, allipids, and cortilids are the sort of snakes that cause that. And why it's like what the effect is, it prevents the release of acetylcholine from that synaptic junction. So it just stops transmission, full stop. Then you've got your postsynaptic, which are the alpha neurotoxins, and these have rapid effects, so much faster, but you can reverse it. So you can give the antivenom anytime, and you can cause full healing. And you can also give some drugs called anticholinesterase. You'll learn about them later on. So just know that they're an option, I guess. And allipids and sea snakes are usually what have those alpha neurotoxins. And what they really do, they act on that postsynapse and they prevent nicotine receptors from being responding to that acetylcholine. We had those hemotoxins, which they cause blood coagulation. And so snakes that, not tigers, snakes that have that are examples of those are tiger snakes, taipans, and Steven's banded snakes. They want you just to know that one. I don't know why, but pretty much what they do is they have prothrombin activator, like sort of effects, which acts on something called prothrombin, which makes something called thrombin, which is what we need to make fibrinogen become fibrin and so cause that clot. And you'll actually do this later on. You'll have an entire lecture on blood clotting. And so you'll get the gist of that later on. Some snakes, uniquely, not Australian ones, but some snakes have venom which actually has anticoagulant effects. So they didn't talk about it much because it's not really relevant to us in Australia, but just be aware that there are snakes that have the opposite effect in their venom. So the signs and symptoms that you'll see if someone has been bitten, I guess, something called partial ophthalmoplegia, which is just the eye muscles are paralyzed. You've got double vision, loss of facial expressions, a difficulty in speaking, pain on muscle contraction, muscle weakness, darker urine, something called ptosis. I think I don't know how to say it, to be honest. Maybe it's ptosis. I don't know, but it's ptosis. Ptosis. All right, ptosis, which is just the eyelids drooping. And finally, your respiratory muscles can become paralyzed, and that's obviously where you get more dangerous sort of effects. Just be aware, there's a measure we use called the lethality measure, and it's just the dose required of a specific venom to cause a lethal effect. And so it's defined by something called LD50, which is pretty much how much is required, like how much the dosage required to kill 50% of the population of mice within 24 to 48 hours. So that's just the measure we use. So the smaller that number is to cause that, the more lethal the venom is. So in terms of snake treatment, the first aid is pressure immobilization, and it's above where you've been bitten. So you have to put like a bandage really firm on top, for example, and anywhere on top of that. And why we want to do that is we want to slow the lymph flow, because that's what's going to be spreading that venom. So you want to stop it as much as possible so you avoid spreading it and getting systemic effects. And you can maintain that for around hours, because it'll be still there in hours. And once you do that, you want to find antivenom and obviously neutralize. And each antivenom is going to be different for each species. And we get the antivenom by pretty much injecting animals with a antigen from the snake, or like from the venom, and they will eventually get immunity, and we get the antibodies, harvest them, and use them as our antivenom. So now the second species of the box jellyfish, and pretty much they have tentacles with two different types of nematocysts, which are the specialized cells. They either deliver the venom, so like they're the venomous ones, or the things that stick on, which is annoying because then it's harder to remove. And in terms of symptoms that they can cause, especially the box jellyfish, symptoms they can cause is obviously terrible pain, edema, which is fluid accumulation in certain areas, depending. Usually in this respect, it's like the legs or lower extremities, loss of consciousness, something called wheal, which is just itchy area like itchiness in the area of skin, and then permanent scarring. And the first aid for box jellyfish is to pressure immobilize. Pressure immobilize, is not recommended, so you don't do that. Instead, what you do is obviously remove them from the water. You use vinegar to remove the tentacles, not alcohol. A lot of the time, people assume it's that that acts the same way, but it doesn't. So vinegar is the protocol, and usually in many beaches, especially if that like people know there's box jellyfish in the area, there's going to be like a place or like a little post where you can find vinegar inside. So just look for those as well, and then monitor the vital signs of the person until you can give them antivenom. And so there is a group of symptoms, I guess, that we call it Urkinje syndrome, which is pretty much where the venom causes tachycardia, severe hypertension, and even cardiac arrest. So it's a really big deal. So not everyone will get into this syndrome, but if they do, that's when it's life-threatening and people can die. So just be aware of that. If you see a patient in that respect, it's a critical case. Finally, spiders, two species we're going to sort of look at, the redback and the funnel web spider. I was going to find memes for this stuff, but there was like nothing funny. They were all either terrifying or like just like not funny. It was just, yeah, so I couldn't make this funny, I'm sorry. But pretty much, redback spiders, their venom acts pre-synaptically on that first neuron, and it causes the release and depletion of all the noradrenaline or acetylcholine. So all the neurotransmitters are released. And so then you can't really do anything after that when all of it's used up. And so it leads to paralysis, like we call it patchy, because it's like in different areas, random spots throughout the entire like body. The symptoms are sharp pain at the site of the bite, sweating in the area as well, nausea, vomiting, headache, hypertension, and tachycardia, which is increased heart rate. And these, we call them all adrenergic effects. They act on that same principle. We'll learn more about that later on when you guys get to the NMJ. But in terms of first aid, you obviously just in terms of the pain, giving them an ice pack, but the antivenom is usually what is the main thing. Be aware, pressure immobilization, not recommended. That's really important to remember, because a lot of the time, as soon as someone's been, everyone assumes you got to, immobilize using, some sort of wrapping. But for this case, it's actually contraindicated. Don't do this because it's going to make it worse. Whereas funnel web spiders will realize that it is what you have to do. You definitely have to do that immediately as well. So knowing which species spider is super important, because that'll change the treatment. So these guys, their venom acts on the nerve fibers themselves and makes them release or cause APs repeatedly and spontaneously, which will cause a lot of muscle twitching everywhere, which is an issue, I guess. There are two phases, I guess, in terms of the symptoms. The first phase, like more the acute phase, and the second phase, like more like prolonged sort of effects. So obviously you're getting pain at the site, muscle spasms, tachycardia, hypertension, nausea, vomiting, abdominal pain, extra salivation, and then something called lacrimation, which is just a lot of tears, excessive amounts, which is abnormal. And unfortunately, this can cause death, because there's something called pulmonary edema, which is where a lot of fluid accumulates in the lungs, making it hard to breathe. And so that's something that can also happen, that phase one. Phase two is like the after effects, I guess. And you can get hypotension, not hypertension. So in phase 1, hypertension, which is high, you can get low, so hypotension. Then you got cessation of breathing, which is you stop breathing, and then cardiac arrest. So it's pretty bad, So just be aware. You've got to act quickly. So pressure and mobilization as fast as possible, and then anti-venom. And yeah, and then I tried making my own meme. So I'm not crying because you're afraid of the spider. I'm crying because of the lacrimation. But yeah, I think that's it for envenenation for today.
Now I'm going to talk about the integumentary system, and I apologize in advance. So this is about the skin. So yeah. Yep. Okay, so first I'm going to talk about thick skin. So this is the skin found on the soles of your feet, on the palms of your hands. So basically where it is hairless. So hairless and thick go together. So you've got a thick layer of the epidermis. You've also got the dermis. So you've got, with the dermis is just, you can see it here, layers of collagenized connective tissue, and which interlocks with the epidermis. So, sorry, the dermis is down the bottom and the epidermis is at the top. So you've got the layers of collagenized connective tissue down the bottom, which then these invaginations of the epidermis push down through papilla, which are what these pointy bits are. And then you've got the hypodermis, which is not visible in this image, which is mostly composed of adipose tissue. So what you do need to know though is the layers of the epidermis. So I've done these from bottom to top, but the easiest way to remember them is from top to bottom. And the mnemonic from top to bottom is "Come, let's get sunburnt," or "Cute ladies get sunburnt." So that's stratum corneum, stratum lucidium, stratum granulosum, stratum spinosum, and stratum basale. So the basale is the closest layer to the dermis. That's right on the bottom. This is a single layer, and there's still living cells, and nearly all of the cell divisions occur there. Then above that, you've got the spinosum. This is still living as well. You've got these desmosomes, which firmly attach the cell to the neighboring cell, and it can really allows the skin to really withstand very strong abrasion. And sometimes you hear this being called prickle cell layer. The next layer up is the granulosum. So this is where these deep purple keratohyalin granules are. There's a lot of words there. Just remember that it's dark purple. So during like the keratinization, so these this is when you get the keratin forming in the skin, and then the phosphate is cleaved out, and so they're no longer wanting to stay at the bottom. And this is where the cells lose their nuclei and organelles. And then above the granulosum, you've got the lucidium. So this is the thick layer of dead cells, which are just full of keratin, tied together by fibers, just a formless, featureless mass. So they're just all flattened dead cells with just heaps of keratin in it. And then you've got the corneum, which is right on the top. So this is just flakes of cells shed from the surface. So dead cells, just layers and layers of keratin. So it can be between like 10 layers deep or several hundred cell layers thick. And then, so that was the epidermis, and now you've got the dermis. So you've got kind of two layers of the dermis. So you've got the papillary layer, which is right beneath the epidermis. So those were those big, long things that I showed you earlier. And that's composed of loose connective tissue. And so you've got the blood capillaries, which are running through those papillae. And these are the ones which are nourishing and keeping the keratinocytes alive. And then you've got the reticular layer, which is dense, irregular connective tissue, which is bundles and bundles of collagen, and it's really thick. So a key one, an example, and I've got an image on it on the next slide, is the sebaceous gland. So this is where the sebaceous gland is like a gland that's secreting sebum. So So you've got the stratum basale and the spinosum. They're invaginating into the dermis, and so they're going to become the outer epithelial root sheath. So where this epithelium is coming in and is losing the keratinized layer, these outpocketings form a foamy sebaceous gland right next to the hair follicle. So this is known as holocrine secretion. So the entire contents of the cell are shed, and that is what causes the sebum. So along the basal lamina of this gland, that's where the cells are dividing. And then the daughter cells are pushing up into the sebaceous gland, filling up with lipid droplets, which gives it kind of spongy appearance. Eventually, these cells just degenerate all on the inside. And so the cell lyses, and all of the contents of the cell join the secretion at the top of the gland. And then that's what the sebum is there. And then just below that gland, you can sometimes see a small, thin pink gland of smooth muscle. So this is the erector pili muscle. This is raising the hair and then squeezing. As it raises the hair, it squeezes the oily sebum onto the surface. So if you go on to the next slide, you can kind of see all this. So we can see how the epithelium has come right into the dermis, and we can see this hair gland here, and we can even see that erector pili muscle just along the outside, that thin band there. So this is a good image to have a look at our slides later and keep that, because that really shows where everything is. These are just some more cells. I'm going to really point you to these corpuscles because they will come back later when you talk about the sensory nervous system. So just quickly, the melanocytes. So this is synthesizing melanin. They're in the basal layer of the epidermis, so the stratum basale. So yeah, this melanin is passed along to different keratinocytes. So as they move up and up, they get rid of the keratinocytes get rid of this melanin that's secreted by the melanocytes. Then you've got enzymatic Merkel cells. These are also involved in the sensory nervous system, but it's kind of like we don't really know exactly what they do. You just kind of need to know that it exists, and they will come back later as well. Like I think it's next semester sometime. The next one, you've got Langerhans cells. So these are essentially like the phagocytes of the skin. So these they go up into the epithelium to get the antigens, and then they go back to the lymph nodes, and they're trying to work out if there's any infection there. The next ones are the important ones. So we've got the mucinous corpuscles and the Pacinian corpuscle. So the mucinous corpuscle, these are like sensory nerve endings. So these are directly under the epithelium. They're in the papilla. They're sensitive to light touch. They're kind of like flat cells stacked transversely. And so if you've got a whole heap of nerve endings invading in these cells, and then they go and join together to form that sensory nerve. And the next one you've got is, so this one's right in the dermal papilla. The next one is right much deeper in the skin, so the Pacinian corpuscle. And if you look at like an image of it, they kind of look like onions because it's kind of like a big, like you can imagine just a whole heap of concentric circles. Yeah, so this is a large myelinated nerve fiber going through the corpuscle, and it is responsive to pressure and especially vibration. So we're remembering mucinous, closer to the surface, sensitive to light touch. Pacinian, much deeper, sensitive to pressure and vibration. The next thing I want to talk about are sweat glands. So these are just like epithelial cells wrapped around secretory cells. So you've got an abundance of actin and myosin in the cytoplasm. So they're secreting sweat onto the surface of the skin. So these are particularly abundant on like the forehead, in the axilla, which is like under your armpits, on the palms and palms of your hands and soles of your feet. So you basically get like a tuberous duct passing from the epidermis into the dermis. And you've got like a double layer of cuboidal epithelial cells It's surrounded by some adipose tissue. The secretory section is lined by like a pseudo-stratified layer. So from recalling back to our epithelium lectures, what pseudo-stratified means, it looks like it's stratified, but it's actually not. And these, release sweat, essentially. Cool. That's all from me.
Yeah, and I just have anti-cancer drugs and treatment. Farm, which you'll come to kind of realize is very almost memorize just the names. However, it's important to understand like the mode of action, because I feel like that really brings it together. So always for every drug, memorize drug name, mode of action, adverse effects, and then possibly like contraindications, so like who not to give it to, and like also who to give it to. And then you very rarely need to know dosage, and usually all of them are just taken either orally or IV, but some have specific. But we'll get into cancer drugs. Yep. So we have first like our group of classic cytotoxic agents. So these are just your classic chemotherapy drugs. And these all target rapidly replicating cells. So you can imagine that it has that really strong desire for growth. However, when we want to kind of target these, we target kind of the replication processes. However, they're not very specific, so they can have a wide range of adverse effects, because they're just essentially targeting replicating cells, not specifically cancer. So the first group we have is,
just to add on to that, sorry, so like that's why you see a lot of the side effects, I guess, of cancer treatments cause hair loss and things like that, because these cells are the ones that divide a lot. And so sometimes we can realize what sort of each of the different side effects are based on the cells that are just dividing a lot.
Yeah, exactly. So we can return back to this later, but just these are roughly where all your chemo drugs are going to work. So the classic ones. So we have our cycle specific, which work in like either like the M phase or like parts of the S phase. However, we have like our alkylating agents, which work like the whole time. So they would be known as cycle non-specific. So they can have a like implement or like kill a cell during the entire cell cycle, whereas others are more specific to specific parts of replication. Yeah, so if we go to the next one, these are general adverse effects that we're going to have for essentially all of our anti-cancer drugs, as Ivy was saying. So we're going to have like alopecia, skin blistering, GI sores, inflammation of the mouth, nausea and vomiting is a very common one. And also that's very important, because the nausea and vomiting is so intense that sometimes people actually used to opt not to get chemotherapy because it was just too, like they just essentially couldn't do it. And we have like bone marrow suppression, organ toxicity. There's also lots of effects of like on your actual immune system, because those are also rapidly dividing cells. But essentially all of these adverse effects you can kind of see, because you're targeting not just those cancer cells, but any cells that rapidly replicate, like things like your skin cells inside your GIT, and then also that would be reasons for infertility, also those dividing cells, and then organ toxicity, just side effects of also all these drugs. And kind of some ways that we can kind of stop this is those antiemetic agents, which is kind of going to stop your nausea and vomiting. And we also have things that stimulate blood count. So like might give erythropoietin, which kind of increases red blood cell production, and also filgrastim, I don't know if I said that right, which will increase your white blood cell population. And that just kind of assists your immune system kind of fighting also these cells and reducing side effects. Okay, so our first group of our alkylating agents, everything I've got in green are kind of the drugs to know. So how these work, our alkylating agents, they essentially insert a alkyl group into a DNA structure. So imagine you have your cell and you've got the DNA inside it, and they essentially just establish these groups onto parts of the DNA, which then allows cross-linking to form between G bases. And then the strand actually can't unravel, and it kind of just stresses out the DNA breaks the DNA, and this kind of leads to apoptosis. And this could work anytime, which makes sense because you're just attaching something. It's going to just kind of stress it at all times, not even to open the DNA when replicating, but even like normal cell processes, that DNA can't be opened. And the drug to remember is cyclophosphamide. You don't really need to know about that, what it produces, just know that forms that cross linkage across the DNA strand. And this is a kind of a memorizing tool, is the cyclo. It kind of makes sense because you're kind of, first of all, it's cycle non-specific, but also you're kind of establishing like I kind of thought of it as like a circular thing because you're like adding extra things and then it can't break. Yeah, next one. We have the cytotoxic antibiotics. So these usually could be used potentially for really, really severe drugs, bacterial infections. Just they have such extreme side effects that they're not used. But these essentially inhibit transcription and translation processes. So you can't stop like the cell from carrying out functions because it can't actually implement, like make its own proteins. So we have doxorubicin, which essentially intercalates with DNA and it makes this like structural change. It generates all these really toxic things to the DNA and damages it. How I remember this was just the doxo, the X, OX, and the same as cyto, toxic, so the OX there. So just remembering those together. Then the next one, we have the antimetabolites. So these essentially block the ability to make for the cell to replicate because you don't actually have any kind of building blocks in which to make the DNA from. And this would be cycle specific in that S phase because they kind of stop the production of DNA, which makes sense. They'd stop the cell from replicating only in that S phase. So the two to know are 5-fluorouracil and methotrexate. 5-fluorouracil stops DNA and RNA synthesis, and methotrexate kind of works a bit further on than that. They're folate analog, so it stops the actual synthesis of purines production for which DNA and RNA can be established from. Then we have kind of our hormone antagonists. So these are usually for positive breast cancer, which means estrogen positive breast cancer. So breast cancer that kind of grows off of the hormones of the body, specifically estrogen for females. And essentially how this works is if you imagine that the cancer cell is being promoted, like the growth is promoted by kind of ligands of the hormones. If we actually stop the hormone from acting on that receptor, then the downstream processes of like cell growth can't occur. So we have tamoxifen, and this essentially binds to the estrogen receptor and prevents access of the estrogen, so stops those down things. And we also have anastrozole, which actually stops the breakdown of estrogen from fat. Yeah. Oh, actually, if we go back, sorry, a memory technique. This is kind of a bit average, but like TAM, I kind of thought of like as like tampon. So it's kind of reminds of like female breast cancer. And that was it for those memory techniques. And then these are kind of new drugs that have been created because of, if you could think about how cancers have specific kind of growth patterns, the more we can kind of target a drug to specifically act on certain types of cancer characteristics, the less side effects we're going to have. However, what makes this really, really challenging is it takes a lot of process for a drug to be established, and we also don't know so many of those minute changes in cancer populations, which allow us to have a very targeted therapy, so they do have limited use. Yeah, sorry, the formatting stuffed up a bit, but we have our monoclonal antibodies, which essentially, imagine you get an injection of antibodies that are specifically targeted to characteristics of cancer cells. So we have rituximab, which is directed towards that C20 surface antigen, which is overexpressed on B cells to trigger cell lysis. And the next one, I don't think it's actually as important, but it's trastuzumab. I don't actually remember what it's for, but I'm pretty sure it's for HER positive breast cancer, which is for which just means it's an over expression of a certain type of receptor on cancer cells for the breast. And yeah, these ones just maybe roughly know the name, but it doesn't really matter if you don't know the name, because all of these will end in that MAB, so monoclonal antibodies. So that's a really easy trick to remember things by. So as soon as you see MAB, you know it's a monoclonal antibody, you know it's essentially antibodies that have just been injected in to target kind of those antigens on the cancer cell, which kind of direct also the immune cells towards it and also stop like replication. And then we have like this immune therapy. So you can imagine if we kind of booster up the like immune system to be able to fight these cancer cells and give it in addition to other kind of chemotherapy agents, we can kind of have a, like booster the effect of kind of the whole response. So we have our interferons, and these kind of make your immune cells more effective. And at high doses, it also stops cells from proliferating. Yeah, we also have our interleukin-2, and this stimulates lymphocyte proliferation and cellular immunity. And this kind of exposes immune cells to a cancer and just kind of fires up the immune system as well. Then we have our checkpoint inhibitors. Sorry, I'll make sure I change the formatting before these are uploaded. But these kind of just make sure that they kind of switch off the proteins that would allow the cell to progress through the cell cycle. So it kind of again initiates that cycle checkpoints. And then this is a really good summary of kind of what the main drugs are. There's some of these that I haven't included because I didn't think they were as important. But plant alkaloids, they essentially stop, I think, mitotic processes, and there's no actual drug name, they just know that class. And yeah, I think maybe we have one more page. Yeah, okay, so we have our treatments and complications. So we have gone through the adverse effects of our classic therapeutic agents, but there's actual treatment options and complications that arise out of just the nature of cancer. So if we go to the next slide, the first one is our drug resistance. So you can imagine that the cells that actually don't respond to the drugs of choice, they're going to, through like natural selections, they're going to survive, even if all the other cancer cell populations survive. If these cells remain, then, and they're not responding to the drugs, then that's a massive issue. So what we do is we take multiple combinations. So when someone's getting chemotherapy, they're essentially getting a range of drugs from lots of different classes to kind of essentially target from all approaches these cancer cells. They also put these cells on these people on drug holidays. So they have periods where they take like their chemotherapy, then break, then again. And this kind of tries to stop that resistance. Yeah, and then exactly we have that different mechanism of action, and therefore we have that cancer kind of being attacked on all fronts. Our next kind of issue that we have is, this is just like what a drug holiday is. So you give the treatment break, give the treatment, and kind of some of these benefits are you actually give the person time to recover. So even just like the regrowth of immune cells and things like that, and not having to experience all those side effects are really important. And also sometimes you give the drug, it doesn't work right away, but the toxins that are released from some cells also stop the cancer killing other cells. And also, as I mentioned before, with some drugs being cycle specific and cycle non-specific, if we give, you can imagine one time when you take chemotherapy, your cells could be replicating, while at another time they're just in that GO phase, so they're not actually replicating yet. So this kind of allows, if you're taking it at different stages, you're able to attack kind of different parts of tumor growth all at different times. So just make sure you've kind of got everything away. What else do we have? So we have these things like tumor cell sanctuary. So a drug can only actually act on places in which drugs can reach. So for example, if there's limited blood flow or the drugs actually just can't reach that specific or work on that specific spot, you're going to have a really great area for tumors to grow. And we kind of treat this through radiotherapy. So it's more targeted, or surgery, which literally go in, cut out. We also have things like dose exhaustion. So you're giving someone as much as possible of a certain cancer drug, but they're just not like all their cells aren't cancer cells are like there's still some there, or you just can't give any more because they might have a really aggressive form of cancer. And kind of how you do that is again through that multi-drug therapy and combine different treatments as well. And I think that was it. Do we have any more slides? Yes, Evie.
Check. We don't have any more slides, but I was going to just add a point to the dose exhaustion, because obviously all drugs have side effects, or like that if you give in too much, it can actually cause adverse effects. So that's where that dose exhaustion comes in. If a cancer isn't responding well to a drug, there's still a point where we actually just have to stop the drug, or else its effects are going to be negative as well, and it will cause bad things to happen. So it's that balance and that interplay that's really important. And about plant alkaloids, you talked about them before, and I thought I'd probably look at my notes and see what to add about those. So just with those plant alkaloids, there's sort of two different types. The first one's you know in meiosis, how you get the microtubules pulling the chromosomes apart, or so you target those, and so you can't get that. So there's an M phase specific sort of action. And there's another part which inhibits, if you remember in the S phase, you got that topoisomerase, which is this thing that clamps down that the helix when it unwinds. So you can inhibit that as well. And for the Harry Potter fans out there, if you remember the mandrake root from Harry Potter, that same plant is what we get those topoisomerase inhibitors from. So it's a bit of a fun fact for anyone who's interested. But other than that, yeah.
Yeah, and just like one more thing, sorry also about like the slides being a bit boring. I didn't really want to make them too exciting because it's not really too much you can really make exciting, but also just like as an ethical consideration, like when you're treating someone, you have to also be able to make that kind of cost benefit analysis of like how much extra time could I give this person in comparison to the adverse effects, so like quality of life. So like for example, people with very aggressive stages of end stage cancer might not actually receive any kind of drugs for their cancer treatment because just the side effects are not worth it for any maybe couple of days they might receive, or it's just not worth kind of treating them. So that's also just important to consider, that kind of not doing any harm to the patient. That's unnecessary as well. Yeah.
Yes, I think that's it. Thanks guys so much for attending another week. It was fun, and hope to see you guys next week. I'm sorry about the timing for this one. Your farm shoot was just, had to take our spot, but the YouTube link is up there. It will be up there hopefully, and the slides. And if you have any questions, obviously feel free to message us and we're happy to help. Thanks again and have a great day.